I'm Dr. Asim Javed and I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning of image interpretation in coronary intravascular ultrasound.
So in CTO PCIs, you usually get this kind of an appearance on the IVUS image. What you need to do is identify where the intima is, where the media or the adventitia is, and then you'll be able to figure out if the IVUS catheter is sitting in the false lumen or it's sitting in the true lumen. And you need to remember the normal structure: lumen, intima, media, adventitia. This is what you need to remember, and then identify those structures here, and you'll have no problem figuring out things for yourself. So if we start identifying structures, that's the wire artifact. The most outer layer is adventitia, and then inner to adventitia is supposed to be media, which here seems to be quite big. Now if I take, there is a black line here, if I say that adventitia is here, this is media, and this white line, thin white line is intima, well then the media should go all around, but this black line is not going all around. So then where is media? So this is supposed to be media in that case, although it's too big, but this is supposed to be media. So let's suppose for now that this is media. Then in that case, this white line should be intima. And intima usually comes all around. So if you see, this intima is here and it is going all around like this, and in between should be the true lumen then. So where the IVUS catheter right now is, this is actually the false lumen. This is the media, which is so big because of the blood collection in it, because of the hematoma in it. And this on the other hand is the true lumen. And remember that in these CTO PCIs, the true lumen usually appears like a fish mouth appearance. So if you have a fish mouth appearance like this is your true lumen, the remaining is all false lumen. And then the question remains, why do we have this black line here which represents media, but it actually is not media because it's not all around. So what happens with CTO PCI is that your CTO wires go into the adventitial layer at times and cause injury there, and the blood leaks into the adventitia and gives you this kind of an appearance, which you should not mix up with media because this is not circumferential.
Now this is again CTO PCI. You can see the guide catheter extension sitting here, and if you look at the IVUS run, and I'll show you a still image of it as well. So there you can see a fish mouth appearance appearing right here. So you can see this fish mouth appearance. So this is the compressed true lumen, and the IVUS catheter is present in the false lumen.
What you need is three-layer appearance for a true lumen. That is, it must have intima, media, and adventitia. So if I go back to the same picture and I consider this true lumen, in that case, if this is lumen, this is intima, then this is media, and then this is adventitia, everything can be explained. So branches will come off from the true lumen. False lumen will have no arterial branches, and if you give contrast injection, the contrast will hang in the false lumen, whereas it will easily clear from the true lumen. But we don't give this contrast injection because it will otherwise increase the dissection and the hematoma. Now another picture for comparison. In the previous case, we had our IVUS catheter sitting in the false lumen. Here if we start identifying, that's your IVUS catheter. This is the wire artifact. The innermost layer is intima. Then the black line going all around is the media, and if you see, media is going like this, it is going all around, all around, all around, all around, but here it increases a lot in size. So maybe there is something in the media. So adventitia is the outermost layer. Then what is this? This is dissection or intramural fresh blood. Why do we call intramural? Because it is in the muscle. Where is the muscle? Muscle is in the media. Media is all smooth muscle. So this is intramural fresh blood, or it is bleeding in the media. And this is fresh blood, and in comparison, and this is the false lumen, this is something which is thrombus. So there is a thrombus as well sitting in the media. So the IVUS catheter here is in the true lumen. In the previous case, it was in the false lumen. Another case to identify. So what is this? This is the intima, this is media, this is adventitia. But then there is something black here and then there is adventitia here. So what's happening is, you can see here why I'm calling this media, because media is going in circle like this, it's going all around, all around, all around, all around. But then, and then there is adventitia as well. But why do we have this big space here? Because this is the space within the adventitial layers. As I explained earlier with CTO wiring, you can have blood collection here. So just going through a case quickly, RCS CTO, where you have an ambiguous proximal cap here, but luckily you've got a nice sizable branch here in which you can take your IVUS catheter, and on the way out you can identify where the proximal cap is. This is what we did. So this is an IVUS guided puncture of the proximal cap. So you need an 8 French guide if you want to accommodate an IVUS catheter and a micro catheter simultaneously. So this must be remembered. If you want to have an IVUS guidance live puncture, you've got to have a micro catheter in there as well for the wire exchange and support, and for that you need an 8 French guide catheter. So we did this puncture with IVUS guidance, and that's the final result. Next case, we've got an LED CTO, and again an ambiguous proximal cap and a nice sizable diagonal coming off. It's difficult to figure out where LED is occluded, but where the IVUS tip is, that's the place where we actually found the LED coming off on IVUS. I'll show you the IVUS now. So that's the IVUS image. If you look at 3 o'clock, you can see a branch coming in, a big branch coming in and meeting this diagonal where the IVUS tip is. So this big branch coming off here is exactly at the spot, at this spot where I just showed you that there is, that's where the big branch was coming off like this. So there you can see at 3 o'clock. How do we use the wire? We use the wire artifact to our advantage, and we can move the wire. I want to move the wire into 3 o'clock, so I'll move the wire's artifact into 3 o'clock position, and that's the position in which I need to puncture the proximal cap. But here the IVUS has moved from its place, so we need to make sure that we are exactly at the same spot where this opening is, and then we puncture with our wire with the artifact in 3 o'clock position in this case. And then here you can see, after we've done the wiring, this is an IVUS run to show that the wire is coming from the main LED into this branch. And remember that if you've done the wiring properly, the wire will be surrounded by plaque when it's gone into the proper position, because CTO body has plaque in it. This is another case where IVUS guided CTO PCI was done. And you can see that there is an ambiguous proximal cap, there is a nice sizable diagonal there. So we did the IVUS guided puncture, and puncture was successful. You can see the wire surrounded by plaque coming all the way and back into the main lumen. And I had a loop on the BMW wire in the diagonal. So after I put a stent into the main LED and I'd taken the final picture, I wanted to remove my BMW wire. I was a bit casual. I did not pay attention that the wire is coming back with its loop, and I realized when I had a jerky feel in the wire while I was pulling it out, and I realized that I had it jailed or stuck in the stent, and unfortunately it not only got stuck, but it also kinked right at the stent strut level. So then I tried a fine cross. I tried to push it back into the diagonal, did not succeed. I took a fine cross to go behind the stent on this wire, it did not succeed. I took small size balloon, I think it was a 1.25 balloon, the smallest that I had on the shelf at that time. I wanted to go behind the stent struts, did not manage that. Then I sort of pulled it back slightly to see if it can get released. But unfortunately with that pull, I realized that I had deformed the stent and pulled it into the left main stem, Now the deformed stent is hanging in the left main and the wire is further kinked and there is no way it's coming out. So I did not have any further choices at that time. I knew I had to pull it out now or hand over the patient to the surgeons. So I pulled the wire out and I managed to break the wire actually, but unfortunately the stent also got elongated and was hanging in the aorta now. So then I brought in a snare. This is an N snare 3 loop, and with that I grabbed whatever was hanging in the aorta, and with that I again pulled everything out, and when it came out we realized that this was a lot of stent material with it, and the wire had unraveled and it was also hanging probably in the ascending aorta. So I immediately did an IVUS run. Luckily the patient was still stable hemodynamically, and on the IVUS I saw that the distal part of the stent was okay, but in the proximal part it was fractured and a lot of stent struts were missing, and then in the left main it was crimpled in the left main. So without any further delay we rewired the LED and the circumflex, took another stent and implanted the stent from the left main ostium into the LED covering the fractured part of the stent, post-dilated with 4.5 millimeter non-compliant balloon, and the final result looked good. But you can see here that the unraveled BMW wire is jailed behind the stent, and some of it is also hanging in the ascending aorta. So this patient had to be kept on dual antiplatelet therapy and probably will continue lifelong dual antiplatelet therapy. This case was done I think almost 4 years ago, but he's still doing well and he's still asymptomatic. This is another case where my colleagues were doing the case and they had this dissection, and unfortunately they still gave another injection and the hematoma increased in size. So I took a Fielder XT wire with fine cross, managed to cross it, needed an anchoring balloon 215 to get the appropriate guide support, did an IVUS after that, and you can see the typical fish mouth appearance appearing here. And when we did the chroma flow, you can see that the chroma flow is also following that fish mouth appearance. So the IVUS catheter was in the true lumen proximally and distally, but in this dissection part it was in the false lumen. So after seeing this we put in a stent, and this is the final result. So this is another case which I presented in C3 meeting, and I'll go on to the actual live presentation which I did virtually because of the COVID days.
Thank you very much again, and it was a wonderful webinar, great learning points all over and excellent cases shown. So I can't show you anything more complex than what has been shown already, so I'm going to show you a rather simple CTO, but it has an interesting learning point in it. So my patient is a 55-year-old gentleman. He had angioplasty done about 4 years ago with a bare metal stent to the right coronary artery and a drug-eluting stent to the LED. So this time he presented with effort angina CCS class 3 despite of optimal medical therapy. So as you can see, there's a 100% ISR of the RCS stent, very ostial placement, and the mid LED stent is patent, and you can also see the distal RCA being cross-filled from the left system. The difficulty that I had in this case was my initial plan was to go integrate here, but it was very difficult to engage any guide catheter and to make it sit coaxially in the right coronary artery. So I tried different shapes and everything and nothing worked. So I tried wiring, staying slightly away, but it just wasn't possible to go with an antegrade approach here. So I decided to go retrograde, and the septal that I selected was this septal which was relatively straighter, but it was coming out of the middle of the LED stent. It wasn't difficult to go through the stent and into this septal,
I used a Corsair and Seon wire and could manage to go retrogradely. Came up to the stent, and then in RCA stent I used a Pilot 200 to go across, and then I didn't have an RG3 at that time, I used a Rota floppy wire for externalization later on, and just to save some cost did not opt to go with an anti-grade micro catheter and change the wire. So rather I brought in a 338mm drug-eluting stent on my Rota floppy wire anti-gradely and deployed the stent. So this is the result after doing everything else. But the problem here again was I still could not manage to engage my anti-grade guide catheter coaxially. It was still giving me a very hard time. So I decided to bring in an IVUS catheter to see what exactly was happening here. So this is a still image to show you what exactly was seen on the IVUS. So what I think happened here is, this is exactly what happened. I came retrogradely, the old RCA stent is deployed here, and I think it probably wasn't hanging that much into the aorta as much as I've drawn here, but I think my wire, instead of exiting through the middle of the stent, it probably exited through one of the side struts, which I could not realize at that time. So my whole ballooning and stent deployment, I think, was done through the side strut rather than through the middle of the stent. So what we see here on the IVUS is that the IVUS is clearly outside the stent. So initially you see the IVUS catheter outside the stent, and then as we push the IVUS catheter into the stent further down, you can see two lumens of the stent. One is the new lumen which has been created with the newly deployed stent, and the other one is the old collapsed stent in the initial maybe 2 or 3 struts that are now collapsed. So next thing after realizing this is we bring in another 4 by 12mm stent, make it slightly more ostial, and then give it a good blow up, flare the stent properly with a 4.5mm stent, and then after stenting, this is the IVUS run. You can see now it's much better deployed, and you can see that initial part of the stent, which was much bigger initially, the old collapsed stent, now it's relatively smaller here, and this is that part of the stent which is now hanging in a millimeter or 2 into the aorta. So this part could not be collapsed any further because there is no RCA wall to collapse it against. And this is then the final result, and now the catheter could easily sit in, and so it was a simple CTO approach coming retrogradely, but it was an interesting learning point that this can also happen, that at the end of the procedure the wire exited from the side struts rather than going it through the middle of the stent. Thank you very much.
IVUS guidance in CTO cases can help identify location of the proximal cap, confirm successful penetration of the proximal cap, differentiate true and false lumens, determine the true vessel size, and then most importantly confirm optimal deployment of multiple overlapping stents, which is important for reducing restenosis and stent thrombosis. So IVUS guidance has a lot of role in CTO PCI.